In this section, we're going to look at several of the skills related to the airway management of the trauma patient. The first skill we'll look at is recognizing and managing tension pneumothorax. While this is a fairly rare occurrence, it is critical to recognize it and management early on, which can be life-saving. However, failing to recognize this en route to the hospital can be a critical mistake. So the first thing we'll talk about is which patients have a tension pneumothorax that needs to be managed. The patient who has a chest injury and displays respiratory distress that is getting worse, also has diminished or absent lung sounds on one side, and has hypotension or decompensated shock, which may be recognized simply as no radial pulse. Remember that for this course, the patient must have all three of those in order to qualify for needing a needle placed in his chest. We'll look at the landmarks and then we'll go through the procedure. So the landmark should be on the side that has no lung sounds, looking below the clavicle to the second and third intracostal space. Remember, just below the first intracostal space, or just below the clavicle, is the first rib, which would be the first intracostal space. So the second rib you see will be where the proper space is, and then the third rib will be the optional space. If we really look at this, it's going to be just about midway between nipple line and clavicle. So as we perform the procedure, remember what you need is a 14 gauge, 3¼ inch needle at minimum. We've realized over the past several years that that's the standard that's needed to get through the pleural cavity on most patients. Recently, we've seen the advent of several 12 gauge or 10 gauge devices with a built-in valve that you may see used in some areas. We're just going to demonstrate the standard 14 gauge catheter going through the pleural cavity to decrease the tension pneumothorax at this time. So prep the site that you've already found at the second or third mid-clavicular space with the choice that you use, chlorhexidine, betadine, or whatever you use in your system. Once that's done, remember that the needle should be placed over the top of the rib. So find the top of the rib and just angle it very slightly over the top of the rib and push it through the pleural cavity. Remember that this needle is going to go in all the way. Once the needle is in, remove the needle, leave the catheter in place, and in reality, that's all you need. You now have created a one-way valve for air to come out. A small amount of air could enter. Some services will use a commercially prepared one-way valve of some sort. However, just getting the hole in the chest is the life-saving procedure. Do whatever you do in your system.
The mid-clavicular approach as well as a mid-axillary approach have been taught for years. A newer approach seems to be the anterior axillary line, 5th or 6th space, as there seems to be less fat and less tissue to get through to get into the pleural space. A finger thoracostomy, as you would perform prior to placing an emergency chest tube in the medical facility, is now being used to manage tension pneumothoraxes in the field. So the procedure is completed in the 4th or 5th intercostal space mid-axillary using a large curved forceps or Kelly clamp and a scalpel. Just above the rib, a 1-inch incision is made. After that, the curved forceps will be placed into the hole and pushed until it pops through the pleural lining. You will see it pop through and feel it pop. At that point, we spread the forceps open to open up the chest wall, and you'll see some blood and or some air rush out at that time. The finger with double gloves is then placed into the hole and moved back and forth to assure that the hole is open.
So when we talk about ventilating the patient who has significant trauma, The goal is make adequate tidal volume, that is, make the chest rise. So let's start out just talking about quick, simple, basic airway management. We know that spinal motion restriction is still considered a concern, whether or not you use a spine board. So the first device for maintaining the patent airway is the oropharyngeal airway for the patient who does not have a gag reflex. Remember, measuring that has not changed from the angle of the jaw to the corner of the mouth. So we place that into the patient as appropriate, and then if possible, ventilating that patient with two persons gives a better mask seal, makes it easier for the person who's ventilating to get adequate tidal volume. The nasal pharyngeal airway is used in patients who have a gag reflex who still need airway management based on the fact that they're snoring or gurgling. They're not able to accept an oral airway, like I said, because they either have clenched jaws or have a gag reflex. So this goes through the nose. Remember that we can't use this in patients who have significant front facial trauma or signs of a basal or skull fracture, such as bleeding from the ears, CSF from the ears, or a later sign, but bruising around the base of the ears, or battle signs. So we measure this from the earlobe, or the angle of the jaw, to the tip of the nose. The bevel is designed to go towards the septum, so they're designed to go into the right nair. If for some reason you're unable to pass it in the right nair and you have to put it in the left nair, remember that you have to turn the device backwards so that the bevel is towards the septum, and then when you reach the back of the throat or the posterior pharynx, rotate it around so that this is going to go into the back of the throat or down the back of the throat. So now this is keeping the tongue out of the posterior pharynx, and we can ventilate, if need be, as we were. Several different paralaryngeal devices can be used instead of intubation. These devices don't require you to move the head very much and are very quick and generally ventilate well in patients who don't have too many complications, such as requiring higher airway pressure or having a lot of blood or vomit in the airway. Let's look at a couple of those. The laryngeal mask airway is basically sized based on the patient's weight, and once the patient has been oxygenated and ventilated appropriately, can be just put in the neutral position and slid down to the posterior pharynx and inflated very quickly. You notice that the device moves up a little bit as it seats itself, and the patient is then ready to be ventilated. Quick, simple, without much need for airway movement. There are several versions of those LMAs. Some allow you to intubate through them. Some of them have a cuff, some don't have a cuff, some are different shaped. The next device we'll look at is the King airway. The King airway is a double cuffed device that again is measured by the patient's height and placed in without having to move the patient's C-spine. And it's again another esophageal type device or paralaryngeal device. So the spine can remain neutral. The device is put in based on the patient's size and put in to the esophagus. The tip of it sits in the esophagus. Again, quick and simple, inflated. The secret to this device is as you ventilate, you must pull back on the tube in order to have the device seat. Sometimes this seems counterintuitive to what we've been trained in, but the device needs to be pulled back. I've seen an inch and a half sometimes in order to get the device to seat. Remember that with either device, you can evaluate end-tidal CO2 just as you would with a tracheal tube. The studies say that they haven't fully evaluated this. However, you should get an end-tidal CO2 reading with any of the paralaryngeal devices you ventilate with as well. So once the decision is made to intubate the patient and the equipment is gathered, one person will hold the C-spine in the neutral position from the front while the second person intubates the patient. The goal is to keep the spine neutral and use the laryngoscope to move the jaw anteriorly versus manipulate the head. So while I hold the spine neutral, sometimes releasing the front of the collar allows the jaw to move more freely. However, you have to be very cognizant about not letting the neck move when you do that. Tracheal tube placement is then evaluated in the normal manner, checking for epigastric sounds, checking for lung sounds, chest rise, and monitoring end-tidal CO2. Intubating patients in a unique position, such as trapped in a car, pinned somewhere, or in unique areas, sometimes from the front is called a face-to-face intubation. We've also heard this called a frontal intubation or a hatchet intubation or a tomahawk intubation. Frequently takes two people. If we were considering this patient to have a spinal injury, we would put a collar on his neck. But one person would hold the patient's head in a neutral or airway open position based on what we were trying to do. The intubator has to put the blade in his right hand, finds the vallecula, and then pulls forward to see the glottic opening. The left hand then places the tube. So this is the opposite hands of what you would normally intubate with. Once the tube is in, just like any other intubation, inflate the cuff, apply your ventilation device, listen to epigastric sounds, lung sounds, chest rise, and measure end-tidal CO2. Immobilize the tube and the head as you do in any other intubation. Just to give you an idea of how this looks doing the intubation from the front, we've placed a video camera laryngoscope in the same position. In this section, we'll look at removing the helmet briefly. The speed at which this needs to be done really is based on the stability of your patients, that is, his airway and his level of consciousness. So the first person should be evaluating that as well as holding the C-spine neutral by holding onto the helmet. The second rescuer would remove the helmet strap. If this was urgent or critical, I may choose to rapidly cut the strap. I would then take over holding the spine neutral from the back of the neck and occiput and from the front of the neck and chin, while the first rescuer then spreads the helmet and removes it from the patient's head. What I have to remember is that the head is going to be approximately an inch off of the concrete ground or wherever we are at this point. So now I'm holding the head, I'm an inch off the ground. The first rescuer will take C-spine neutral again and place the head back in the neutral position. At this point, if needed, I can apply the cervical collar as I would, evaluate the neck, place the collar, and continue on with my assessment and treatment as normal. The Bougie stylet is a great device for feeling your way into the trachea when visualization is difficult or impossible, whether it be from anatomy, from position, from excessive fluids in the airway, or any other area where you can't manipulate the posterior pharynx or the jaw to adequately see the glottic opening. Ideally, we take this device with a curved end. It's like a soft plastic stylet, and we're going to place our tracheal tube over that. We're then going to use our laryngoscope like we normally would, find the base of the tongue, attempt to find the epiglottis, lift the epiglottis as best we can, but understanding the anatomy, we would take the soft Bougie stylet, slide it under the epiglottis to where the trachea should be, and as we slide it into the trachea, we're able to feel the tracheal rings with that curved end. So we feel this device actually clicking on the tracheal rings. Once we feel that, slide the tube down the back of the throat. Keep the tube beveled end along the base of the tongue so it slides down there. You've now just guided the tube into the trachea by feeling your way in. At this point, inflate the cuff, use your end-tidal CO2, bag valve mask, listen to epigastric sounds, lung sounds, chest sounds, end-tidal CO2 monitoring just like you would with any other intubation.